Why is it so difficult for older, particularly endurance athletes, to know how hard to train?
That's a really key question.
And one we will answer in this video. Whether you're cycling, running, rowing or doing gym work, how hard should an older athlete train not to damage their heart? It also applies to climbers like Dr. Peter Clarkson. He's an NHS cardiologist in the Scottish Highlands. He sees folk like us when things go wrong. He'll also explain who's at greatest risk of sudden, serious cardiac events. You do not want to meet him professionally, so you better watch this. Let's be clear, fitness for health is not just cardiovascular. It's functional strength, mobility, balance, and it's body morphology.
Not just how much fat you're carrying, but what your bone density is. Are you doing weight-bearing exercise is important. I love cycling. I've done lots of cycling. If that's your sole form of exercise, you're going to find it difficult to move through a wide range of motion. It doesn't protect your bone density to the same extent because you're probably not weight-bearing.
That's why this is part of a comprehensive ongoing series looking at different aspects of health for older athletes. As individuals, we have unique issues, so please check with your doctor before exercise. This is not medical advice for you, and Dr. Clarkson cannot answer individual specific follow-up questions. That's the disclaimer done.
But there's always this question is, what is too much? Is there something that's going to cause problems downstream by doing too much exercise? Can we as older athletes do too much? But the cardiac side of things, there's two things we are concerned about, which is coronary artery calcification and atrial fibrillation. And I'll talk a little bit about both of those.
In 2023, a study of about 300 50 to 60-year-old athletes took part in the Mark II study. That's measuring athletes' risk of cardiac events. And more research will take place over the next decade.
Endurance athletes are more prone to getting coronary artery calcification. That means hardening of your arteries, which potentially can cause further cardiac trouble downstream. Now, what the data is telling us so far is that it's particularly common in men, but it's more prevalent in people who spend a high percentage of the time doing very vigorous exercise. And what we mean by very vigorous exercise is things greater than 9 metabolic equivalents, which is generally heavy rowing, running, pushing yourself very hard on cycling events. It doesn't seem that the overall duration of exercise makes any difference. If you exercise for longer, it doesn't seem to make any difference in the amount of coronary artery calcification. So to me, what are the current take-home messages about that? What I would probably view that is that you need to spend a significant proportion of your time doing lower intensity exercise as well. We definitely know that doing some high intensity exercise is good for you. It's good for your VO2 max. It's good for your body, full stop, in lots of ways. And I don't want people to stop doing high intensity exercise on the basis of this small risk of coronary artery calcification. But as I said, it's the high percentage that seems to be the trouble. And so I think sticking to the sort of more 80-20 type of exercise that we're told to do, rather than pushing yourself towards a more sort of 50-50 end, is likely to be more protective to your coronary arteries. But we'll find out more information as the decades progress and we get more information on this matter.
"80-20 training is explored in this video, number 7 in the series. It means that 80% of your training should be done at an intensity where you could hold a conversation but may struggle to get out the last few words. Do intensity, but limit it to around 20%. And this might impact your turbo training, especially in winter. Hard intervals on Zwift or another platform are more interesting than long, steady rides, and they feel like proper training, but they are harder to recover from. And if such intensity is more than 20% of your training, you could be storing up a problem. There's no easy way to check.
No, unfortunately there's not. The studies on this are all based on CT scans of your heart. And the CT scans, I wouldn't recommend people get CT scans of your heart to determine it, because you need to irradiate your chest and to do so. But the data's coming from it from looking at serial CT scans. We don't have a biomarker. There's not something physically evident by looking at someone from the outside. Me as a cardiologist, I can't tell who's got coronary artery calcification without recourse to X-ray. That fixation has continued pretty much for 40 years.
And Peter's love of climbing is equally complex.
I think it's a combination of multiple things. It is actually it's a complex sport. So it's a complex sport that involves not just the physicality of things. I like the puzzling out of things. I like playing chess, so actually I like that sort of, how do I join these dots together to actually move on a piece of rock and actually get myself up these things.
He's a regular at the ledge climbing gym in Inverness. His chosen sport trains his strength, balance, mobility and more, as well as his cardiovascular system. For all athletes, regardless of sport, there is one big red flag to look out for.
Central chest pain on exercise. So if you're getting a discomfort in your chest that's not easily to localize. Most cardiac chest pains, we see people putting a hand on their chest and saying it's somewhere in here. And if you're getting a deep pain that's hard to localize, particularly prevalent on exercise, that definitely you should be concerned that there's coronary artery disease prevalent.
Moderate exercise does seem to protect against a worse type of coronary artery disease, and there's no clear link to it from vigorous exercise either.
The worst parts of coronary artery disease for us are the fattier plaques in your arteries, less like rocks, more like the cheese deposits in your arteries. And they're more prone to rupturing, so they're the ones that are more common to cause heart attacks later on. What we don't know is the sort of downstream effects of coronary artery calcification. So are you more prone to getting heart attacks? We think you're probably more prone to getting angina and limitation from the hardening of your arteries. But it may be that you actually don't get much more heart attacks, sudden death as a result of coronary artery calcification. We just don't know because the data is just not there in abundance because of the difficulties we have in population screening when it relies on CT scans. If I was given the choice of completely normal arteries versus coronary artery calcification, of course you're going to choose the normal ones. But if I was given the choice of hard calcified arteries versus ones that are filled with fatty plaque, I would definitely choose the calcified arteries. You don't really get a choice like that in life though, but yeah.
You have to understand how things are up here.
After hearing that, I wondered what are the implications for HIIT exercise, short high-intensity intervals. Again, the evidence is not yet clear, but it suggests they should be balanced by more moderate exercise. HIIT should not be the only thing you do.
You have to understand how things are.
In part 3, we'll discover who is at most risk of a sudden cardiac event. First, atrial fibrillation and atrial flutter, for which I recently underwent tests. Previously, I'd done a VO2 max test, and the ECG trace showed an unusual heart rate spike. It might have been an early warning of a common problem for older endurance athletes.
Our heart works that you've got the atria on the top, which is where the rhythm starts from, and that's like a booster pump. It pushes a bit of extra blood into the ventricles, which the ventricles are the main chambers that push blood into your lungs or around the body. We know in people who do a lot of endurance and do a lot of endurance activity, they are more prone to getting atrial fibrillation and atrial flutter. Atrial fibrillation is a very chaotic rhythm of your atria. It basically is wobbling a bit like a jelly is. Atrial flutter is an electric circuit caught up in a rhythm going around about 5 times a second around your right atrium that then propagates into your atria, which means it's still inefficient. It means your heart's running at a faster speed. It's not got that contraction booster pump ventricles then contracting and pushing blood into the lungs or around your systemic circulation. Your left atrium has got a blind ending sac on the side of it called our left atrial appendage, just the way that we're born. And in a normal heart, if you're in normal sinus rhythm, your appendage contracts and pushes blood out of it. If you develop atrial fibrillation or atrial flutter, that is no longer pushing blood out of it, and blood can form slow eddies and start to coagulate inside your left atrial appendage. And the concern about that is that there is a small risk that coagulated blood can then dislodge travel around the circulation, and if it lodges in one of the arteries inside the deep brain matter, that you will have a stroke as a result of it. Now, the risks aren't huge, but we definitely do know that there is a risk in people with atrial fibrillation.
At greatest risk of AF are those who do very little and those who do a lot of exercise, and on average it gets worse with time. Every 10 years of heavy exercise, your risk of atrial fibrillation increases 16%, and every 10 years of heavy exercise, your risk of atrial flutter increases 40%, according to some studies.
I see people in my work who are athletic, who develop atrial fibrillation, and a lot of them struggle with it because it does cap the amount of exercise that you do. You lose that booster pump effect of your atria. Your heart rate is often not quite so well controlled as to where it was before. And a lot of the drugs that we're used to putting people on for control of atrial fibrillation, like beta blockers, are generally not suitable for the very athletic population. They cap the amount of exercise you can do. They lower your maximum heart rate, and they often give people a degree of fatigue on exercise as well.
At the time of making this, I am still undergoing investigations. It doesn't feel like AF, but I know it can come without symptoms and might only be detected by a family doctor or other health professional checking something else entirely. Usually, though, there are symptoms.
A lot of endurance athletes are fairly well tuned to knowing what the pulse feels like, and a lot of them check the pulse anyway, and it will give you an erratic pulse rhythm. You cannot predict exactly when the next heart beat's going to be, so you can feel that. Some people don't feel the palpitations or don't wear wearables. You feel capped on exercise, you feel more breathless, you don't feel the same as you did before. People that, when they start getting it, get little bursts. They get paroxysms, we call them, where you get a trigger and it lasts for a few minutes, then reverts itself to normal. And those paroxysms get longer, more frequent over time until it drifts into what we call persistent or eventually permanent atrial fibrillation.
So who is most at risk of a sudden serious problem? It's those of us in mass participation events, when sponsored to raise money for charity, or who otherwise feel compelled to take part.
What is thought is that these people have a different threshold for saying, actually, I need to do this on this day. I don't feel very well. I'm going to turn up and do it anyway. And I think the advice we'd now give people is that even if you're sponsored, that if you're feeling ill on the day when you're going to be doing a long endurance event, please don't do it. It's much better to look after your body rather than thinking, I'll get through it, I'll wing it, I'll be fine, because they probably are pushing yourself at a higher risk by continuing to perform endurance events when you are ill.
Yeah, so the big scary stuff has never really been my bag.
And I think it's very easy to get sucked into the cardiologist way of thinking, which is the physical fitness equals cardiovascular fitness, because there's actually a lot of other facets to physical fitness as well as your cardiovascular fitness. Muscles. Are your muscles strong? The muscle fitness, muscle strength. What's your mobility like? And mobility, I mean that's coordination. You know, is your balance okay? Are you able to move properly and put your muscles through a full range of exercise? Now for me, rock climbing covers both those. You're working your muscles hard. I do when I'm climbing anyway. And you're putting them through a full range of movement, and you're expecting your muscles to be able to contract and provide power throughout a wide spectrum of motion.
Huge thanks to Dr. Peter Clarkson for his time and expertise. I'll release the full interview as a podcast soon. Subscribe, turn on notifications, and you won't miss it. In the next videos, the VO2 max you should be aiming for now if you want to live an independent life in much older age. How to test your VO2 max more accurately than your smartwatch or app, and what to do to raise it.
If you have enjoyed this, then please share the video, share the series with your friends and folks you know online. I am trying to encourage older athletes, and I think this takes a step towards keeping us that bit safer, and hopefully I've got more expertise to come, spend a lot of time trying to find them. In the meantime, you'll find the rest of the older athlete series here and some adventure cycling videos here, and I'll see you again next time. Bye.